I want to tell you something that most surgeons will never say out loud. It's not the long hours that keep me up at night. It's not the complexity of a difficult case or the weight of a scalpel in my hand during a procedure that could go either way. What keeps me staring at the ceiling at 2 in the morning is a specific kind of memory. It's the memory of a patient's eyes, not during surgery, but after. In the recovery room, in the follow-up appointment 3 months later. That particular look when someone realizes that what they went through, the pain, the fear, the weeks of recovery, the money, the hope they placed in a procedure, didn't help them. Or worse, made things worse. In 15 years as a surgeon, I have seen that look more times than I care to count. And I carry every single one of those faces with me. I want to be absolutely clear about something before we go any further. I love medicine. I believe in surgery. I have seen it save lives, restore function, and give people decades they would not otherwise have had. The operating room has been my home, and the surgeons I work alongside are some of the most dedicated, skilled, and compassionate human beings I have ever known. This video is not an attack on the medical profession. This video is about something that every honest physician will acknowledge in private, even if the culture of medicine makes it difficult to say publicly. Some surgeries are performed on patients who did not need them. And in the senior population, the consequences of an unnecessary surgery are not just disappointment. They can be devastating, life-altering, and sometimes fatal. So let me tell you the most important thing about my philosophy. When my own mother came to me with a spinal fracture and 3 different surgeons recommending the same procedure, I told her no. When my father was limping around with a painful knee and his orthopedist was ready to schedule him for surgery, I told him there was a better path. When my sister came to me consumed by fear about her breast cancer risk, I sat with her for hours and walked her through the data until fear stopped driving her decisions. I told my own family the truth I'm about to tell you. This video is about giving you the knowledge and the language to walk into a doctor's office, not as a passive recipient of medical decisions, but as an informed advocate for your own body. You deserve to know what the research actually says. You deserve to know what questions to ask. And you deserve to understand that sometimes the most powerful thing a physician can tell you is that you do not need to go under the knife. Let's talk about the first procedure: vertebroplasty and kyphoplasty. When older adults, particularly women with osteoporosis, experience a vertebral compression fracture, the pain can be extraordinary. We're talking about a sudden, severe, crushing pain in the back that can make it nearly impossible to stand, walk, or even breathe deeply. It is a genuinely miserable condition. And so, when a physician offers a solution, a procedure where medical-grade cement is injected directly into the fractured vertebra to stabilize it and theoretically relieve pain, it sounds like an obvious answer. It sounds like relief. These procedures are called vertebroplasty and kyphoplasty. They differ slightly in technique, but the fundamental premise is the same. Fill the collapsed vertebra with cement, stop the movement, stop the pain. The theory is logical. The marketing around it is compelling. And for years, it was performed on hundreds of thousands of patients around the world. Then the research started catching up. I want you to understand the significance of what I am about to share because it is one of the most striking findings in modern surgical research. Scientists conducted what are called randomized controlled trials, the gold standard of medical evidence, in which patients with vertebral compression fractures were divided into 2 groups. One group received the actual vertebroplasty procedure. The other group received a sham procedure. They went through the same preparation, the same draping, the same local anesthetic, the same sounds and sensations of being in a procedure room. But nothing was actually injected into their spine. And the outcome? Both groups reported similar levels of pain relief. The sham procedure, the fake surgery, performed just as well as the real one. These findings were published in some of the most respected medical journals in the world, including the New England Journal of Medicine, and they were met with significant controversy. as you might imagine, given the financial and professional investment in these procedures. Now let me tell you about my mother. She was 72 years old when she fractured a vertebra in her thoracic spine. She was in real pain. She is a proud, active woman who had always taken care of herself, and suddenly she could not move without wincing. 3 different spine specialists, each of them well-meaning, recommended kyphoplasty. 3 separate opinions, all pointing to the same operating table. My mother called me, and I told her what I have just told you. I explained the research. I explained the sham surgery studies. I explained that the evidence for meaningful, durable pain relief over conservative management was, at best, highly questionable. Then I built her a plan. We worked with a physiatrist, a physical medicine and rehabilitation specialist, and a dedicated physical therapist. We optimized her calcium and vitamin D. We addressed her osteoporosis aggressively with medication. We managed her pain carefully in the short term with appropriate analgesics. We got her moving, gently and progressively. Within about 3 months, she was functional. Within 6 months, she was taking walks and complaining about the weather instead of her spine, which I consider a significant victory. I'm not telling you this story to suggest that conservative management works for everyone, or that vertebroplasty is never appropriate in any circumstance. What I am telling you is that the evidence does not support it as a routine, first-response procedure for compression fractures in older adults. And I am telling you about the risks because they are real. Bone cement is not forgiving when it goes where it shouldn't. Cement leakage, a phenomenon called extravasation, occurs in a meaningful percentage of vertebroplasty cases. When cement leaks into the spinal canal, it can compress nerves. When it enters the venous system and travels to the lungs, the consequences can be severe or even fatal. Add to this the complexity of anesthesia in a 70 or 80-year-old patient who may have compromised cardiac or pulmonary function, and what sounded like a simple cement injection becomes a procedure with a genuine risk profile. Before agreeing to this surgery, you have every right to look your physician in the eye and ask, what does the evidence actually show? And you have every right to try conservative management first. Arthroscopic knee surgery for osteoarthritis. There is perhaps no more common surgical conversation in the senior population than the one about a painful arthritic knee. The cartilage has worn down. There is clicking, grinding, stiffness, aching. Maybe you can feel it on the stairs. Maybe it wakes you up at night. And your orthopedist looks at the MRI, shows you the images of what looks like a deteriorating joint, and recommends an arthroscopic procedure to clean it out, to trim the torn meniscus, smooth the rough surfaces, irrigate the joint, remove the debris. It sounds like maintenance, like taking your car in for a tune-up. Logical, reasonable, and relatively quick. The only problem is what the science says. In 2002, a landmark study published in the New England Journal of Medicine did something genuinely bold. It compared arthroscopic knee surgery for osteoarthritis against a sham procedure. Patients in the sham group received incisions, actual cuts in the knee, but no instruments were inserted, and no surgical work was done inside the joint. They were taken through the full experience of surgery without the surgery itself. The results were unambiguous. The sham surgery group did just as well as the real surgery group across every measured outcome. Pain relief, functional improvement, quality of life. The results held up over 2 years of follow-up. This study was followed by others. Systematic reviews, meta-analyses. The evidence mounted. For osteoarthritis of the knee, arthroscopic surgery does not provide meaningful benefit over placebo. And yet, it continues to be one of the most commonly performed orthopedic procedures in older adults. Let me tell you about my father. He ran his first marathon at 40. He ran his last one at 61, mostly out of stubbornness, mostly to prove something to himself, and partly, I suspect, to embarrass his younger colleagues. By the time he was 68, both his knees were a radiologist's nightmare. The images were genuinely bad. His orthopedic surgeon looked at those images and essentially said, "There's nothing left to work with conservatively. We need to go in." My father is not a passive man, but he trusted me enough to have a long conversation before making that decision. And I told him about the sham surgery evidence. I told him about his risk profile. A 68-year-old man with mild hypertension, which means anesthesia carries real considerations. I told him about the risks of post-surgical infection in an arthritic knee, about the risk of deep vein thrombosis and pulmonary embolism that comes with any lower extremity surgery, particularly in older patients. Then I told him about the alternative. We got him into a serious, structured physical therapy program focused on strengthening the quadriceps and the surrounding musculature to offload stress from the joint. We talked about his weight, honestly, because every extra pound you carry applies roughly 4 pounds of additional force across the knee joint. We transitioned him from running, which he mourned, genuinely mourned, as if it were a person, to cycling and swimming. Low-impact activities that maintain cardiovascular fitness and keep the joint moving without the repetitive pounding. He started anti-inflammatory interventions, both dietary and pharmacological. We had real, honest conversations about what his knees could and couldn't do anymore. He is 73 now. He cycles 40 miles a week. He swims. He is not pain-free. I want to be honest about that. But he is functional, active, and he did not spend months recovering from a surgery the evidence suggests would not have helped him anyway. If you have an arthritic knee and surgery is being recommended, ask your physician directly. Is there evidence that this will outperform conservative management in the long term? Ask for that data. You are entitled to it. Spinal fusion for lower back pain. Lower back pain is one of the most common and most debilitating conditions in the senior population. And there is a version of it, particularly when imaging shows instability or degenerative disc disease, where the surgical solution offered is fusion. The concept is straightforward. If movement at a particular spinal segment is generating pain, lock that segment in place. Stop the movement. Stop the pain. It is a compelling theory, and I want to acknowledge that there are absolutely specific diagnoses, certain cases of instability, spondylolisthesis under particular conditions, specific neurological compromise, where spinal fusion is the appropriate and evidence-supported intervention. I am not talking about those cases. I am talking about the far more common scenario where fusion is offered for non-specific degenerative lower back pain, where the evidence for its benefit over rehabilitation is, to be generous, inconsistent. Here is something that surgeons who perform a great many fusions know but don't always discuss prominently with patients. When you fuse a spinal segment, you do not eliminate the mechanical demands on your spine. You redistribute them. The segments above and below the fusion now absorb stress that the fused segment used to share. Over time, this accelerated mechanical stress breaks down those adjacent segments. This is called adjacent segment disease, and it is not a rare complication. It is a well-documented, predictable consequence of the biomechanics involved. Studies suggest that a meaningful percentage of patients who undergo lumbar fusion will develop clinically significant adjacent segment disease within 10 years, which frequently leads to another surgery, and then another redistribution of stress. And the cycle continues. I have sat with patients in their late 60s and 70s who came in for one fusion and are now discussing their third. I want you to understand that trajectory before you agree to the first procedure. Let me also be honest about what spinal fusion actually involves, because I think the word surgery sometimes abstracts away the reality. This is a major operation. In many cases, it involves hours in the operating room. There is significant blood loss. The recovery period is long and demanding, often measured in months rather than weeks. There is a documented failure rate, a condition literally called failed back surgery syndrome, where patients emerge from the procedure with the same pain or, in some cases, worse pain than before. Add to all of this the respiratory risks, the cardiovascular risks, and the medication management challenges that come with general anesthesia in an older patient, and you have a risk-benefit calculation that demands careful, unhurried consideration. The evidence overwhelmingly supports treating non-specific degenerative back pain with an aggressive, structured program of core strengthening and spinal stabilization exercises, flexibility, and mobility work, pain management strategies that do not require an operating room, and lifestyle modifications that address the contributing factors. Physical therapists who specialize in spinal rehabilitation have helped patients avoid surgery who were absolutely convinced they had no other option. Spinal fusion should be a last resort. It should come at the end of a serious, documented attempt at conservative management, not at the beginning of the conversation. If you are being presented with fusion as a first or early option for back pain, I want you to hear my voice in your head asking, have we truly exhausted every alternative? Hysterectomy for heavy menstrual bleeding. I want to speak directly to the women watching this video, and I want to do so with the seriousness this topic deserves. Hysterectomy, the surgical removal of the uterus, is the second most common surgical procedure performed on women in the United States after cesarean section. And in a population of older women experiencing heavy, disruptive, sometimes debilitating menstrual bleeding, it is frequently recommended. I understand why the appeal exists. The bleeding stops. Permanently. No more cycles, no more management, no more inconvenience or embarrassment or pain. And for women who have already completed their families and who are exhausted by years of managing this condition, the finality can sound like liberation. But I need you to sit with the word permanent and irreversible, because those words carry profound weight when we are talking about removing an organ from a body that did not need to have it removed. Here is what troubles me deeply about how hysterectomy is sometimes presented to patients. It is not infrequently offered as a first-line treatment, or very close to it, before genuinely exhausting the alternatives. Hormonal therapies, both systemic hormones and the progesterone-releasing intrauterine device, have excellent evidence for reducing heavy bleeding, and many women achieve complete or near-complete relief without surgery. Endometrial ablation, a far less invasive procedure that destroys the uterine lining rather than removing the entire uterus, has strong evidence for effectiveness and an entirely different risk and recovery profile than hysterectomy. Non-hormonal medications like tranexamic acid and NSAIDs have evidence for meaningful reduction in blood loss. These are not afterthoughts. These are legitimate, evidence-based interventions that deserve to be tried seriously before a woman is asked to agree to the permanent removal of an organ. The risks of hysterectomy are not trivial. During surgery, the proximity of the uterus to the bladder and the bowel means that injury to those structures, while not common, is a recognized complication. Urinary dysfunction, incontinence, urgency, changes in bladder sensation, is reported by a subset of women after hysterectomy, even when the surgery itself is technically uncomplicated. And here is something that many women are not told clearly enough. Even when the ovaries are preserved during hysterectomy, a significant number of women experience premature ovarian failure. The ovaries stop functioning normally earlier than they would have otherwise, due to disruption of the blood supply. This means the potential onset of menopausal symptoms in women who were not prepared for them and had every reason to expect otherwise. If you are a woman who has been recommended a hysterectomy for heavy bleeding, I am asking you to do one thing before you agree. Ask your physician to walk you, step by step, through every non-surgical option available and explain, specifically and with evidence, why each of those options has been ruled out in your particular case. You are not being difficult. You are being an informed patient, and you deserve a physician who will honor that. Preventive mastectomy for average-risk women. This last surgery requires me to be particularly careful and particularly compassionate, because the fear that drives it is real and it is legitimate. Breast cancer is genuinely frightening. It has touched nearly every family in some way. And for women who carry high-risk genetic mutations, BRCA1, BRCA2, The evidence supports a serious conversation about risk-reducing mastectomy. For those women, in that specific clinical context, the risk reduction is substantial, and the decision, though deeply personal, can be medically justified. But that is not who I am talking about. I am talking about women with average or moderately elevated risk, women without these high-penetrance genetic mutations, who are so frightened, so overwhelmed by the fear of breast cancer that they are seriously considering removing healthy breast tissue prophylactically. And increasingly, in a culture where high-profile celebrity decisions receive enormous public attention, this request is arriving in physicians' offices with more frequency. My sister is one of those women. She came to me about 4 years ago. She had watched someone close to her navigate a breast cancer diagnosis, and something in that experience had ignited a fear in her that she could not turn off. She was convinced that she was next. She had researched bilateral mastectomy. She had found physicians willing to discuss it. She wanted to know what I thought. I sat with her, not as her brother first, but as her physician. I walked her through her actual numbers. I went through her family history carefully. I talked about what average risk actually means, a lifetime risk of developing breast cancer in the range of 12 to 13% for American women generally, which is real, but which also means roughly an 87% probability of never developing it. I explained that for a woman with average risk, the absolute risk reduction from prophylactic mastectomy is far smaller than most people intuitively assume. And then I walked her through what the surgery actually involves. Because mastectomy is not one surgery. It is typically the beginning of a series of procedures. Reconstruction, revisions, complications that require additional intervention. It involves a genuine risk of chronic pain, changes in sensation that are often permanent, and a recovery that is measured in years of adjustment, not weeks. And then I asked her something important. I asked her, are we making medical decisions right now, or are we making fear decisions? Fear is not a surgical indication. What I prescribed for my sister was not a scalpel. It was information, structured surveillance, and, honestly, therapy. Because the anxiety she was experiencing was real and deserved real treatment. We established a rigorous screening protocol. We talked about the evidence for lifestyle modifications, alcohol reduction, maintaining a healthy weight, regular exercise, all of which have meaningful data behind them for reducing breast cancer risk. We found her a counselor who specializes in medical anxiety and cancer risk. 2 years later, she is actively screened, genuinely informed, and no longer consumed by fear. Screening and lifestyle are not consolation prizes. They are powerful. And for the vast majority of women with average risk, they are the right answer. The surgeon who learned to step back. I want to tell you something about who I was when I first became a surgeon. I was eager. I believed in my training and I believed in my tools. I went into that career believing that operating was helping and that more operating was more helping. Medicine, particularly surgical medicine, cultivates that orientation. The culture rewards intervention. The training is built around doing. But 15 years of watching outcomes, of following patients not just out of the operating room but through months and years of their lives afterward, changed me in ways I could not have predicted. I started asking different questions. Not, how do I fix this? But should this be fixed this way? Not, what is the operation for this diagnosis? But, what is the evidence that this operation improves this patient's life? That shift felt at first like a retreat, like I was somehow becoming less of a surgeon. I have come to understand it as exactly the opposite. The most sophisticated thing a surgeon can do is recognize when surgery is not the answer. It requires more knowledge, not less. It requires more courage, not less. Because recommending surgery is easy. There is a protocol for it, a team for it, a system that supports it. Recommending against surgery, telling a patient to go home and work harder in physical therapy, to be patient with conservative management, to tolerate uncertainty without the false comfort of an operating room. That takes a different kind of conviction. I believe, with everything I have learned, that the most courageous medical decision is sometimes the decision not to operate. Doing less is sometimes doing more. Restraint, when it is evidence-based and compassionate and fully explained to the patient, is not a failure of medicine. It is medicine at its best. Before I let you go, I want to give you something concrete. 3 things you should do before agreeing to any elective surgery, particularly if you are in your 60s, 70s, or beyond. The first question you ask your surgeon, not after the surgery is scheduled, but in that room, in that conversation, is this: what happens if I don't have this surgery? Ask them to walk you through the natural history of your condition without intervention. Ask them about the realistic best case, the realistic worst case, and everything in between. You are entitled to that answer. If your physician cannot give it to you clearly, or becomes uncomfortable when you ask it, that discomfort is information. The second thing you do is seek a second opinion, and if the second opinion agrees with the first, consider a third. Not because physicians are untrustworthy, but because surgical recommendations are made by human beings who bring their training, their experience, and yes, sometimes their biases to the table. 2. A second opinion from a physician in a different practice or institution, someone who has no professional or institutional relationship with your original recommendation, is one of the most valuable things you can do for yourself. Any good physician will encourage you to do this. If a physician seems threatened by the idea of you seeking another opinion, that too is information. The third thing is to insist on a genuine, structured, documented trial of conservative management before committing to surgery for any musculoskeletal condition, any pain condition, any condition where the alternatives are real and evidence-based. Physical therapy, when it is the right therapy performed by the right therapist with the right commitment from the patient, is extraordinarily powerful. Lifestyle modification, weight management, exercise, diet, sleep is powerful. Appropriate medication management is powerful. These are not lesser treatments. They are treatments that work. They carry a fraction of the risk of surgery, and they are far too frequently bypassed in favor of an operating table. You are not being a difficult patient when you ask these questions. You are not being ungrateful for your health care or disrespectful to the professionals trying to help you. You are exercising the most fundamental right you have as a human being, the right to understand what is being done to your body and why, and to participate in that decision with full information. The people I think about at 2 in the morning are the ones who didn't have that information, the ones who were not given the time or the language or the encouragement to ask the questions that might have changed their path. I tell this story, publicly, and in this format, because I can no longer be content to have these conversations only in my office with the patients directly in front of me. You deserve this conversation too. I'm Dr. Clarence Martin. I've spent 15 years on both sides of this equation, as a surgeon who believes in the profound good that medicine and surgery can do, and as a physician who has seen firsthand the harm that can come from intervention when intervention is not truly warranted. I am asking you to be your own fiercest advocate, to bring your questions, your skepticism, and your courage into every medical conversation you have, to demand the kind of informed consent that truly means something. And remember, sometimes the best medicine is the one you don't take, and the best surgery is the one you don't have.